Hello and good afternoon, and thank you for joining today's webinar event, the Palliative Care Blueprint, Building and Optimizing a Program. I'm Alex Freeman, Director of Business Development for BlackTree Healthcare Consulting, and it's my privilege to introduce today's speaker, Maureen Kelleher. But first, a few housekeeping items. There will be a question and answer portion at the end of today's event for a few minutes, but feel free to share any questions you have throughout the session in the Q&A section. Also, we will have polling questions throughout the presentation, so again, feel free to answer those when available. The presentation is also available now for download in the handout section of this presentation, but we will also be emailing over a link at the conclusion of today's webinar. Now, without further ado, a little background on our speaker. Maureen Kelleher is a registered nurse and healthcare administrator with nearly 15 years of professional experience in healthcare and hospice. Throughout her career, Kelleher has had numerous senior management positions at hospice agencies across the United States, and is specialized in regulatory and compliance and staff training. As clinical consulting manager at BlackTree, Maureen provides various clinical and operation consulting services to BlackTree home health and hospice providers' clients. She is also charged with developing educational programs for clinical staff and coordinating with executive management to implement operational clinical strategies for improving clients' operations and bottom line results. Thank you, Maureen, and with that, take it away.
Okay, thank you, Alex. Good morning to everybody on the Pacific and Mountain time zones, and good afternoon to everybody in Central and Eastern. And welcome. Thank you for joining us today. Today we're going to go over pretty much the basics of starting a palliative care program. We're going to provide information on how to get started, what reimbursement opportunities are out there, and how to grow a program once you've got it started. So considerations for a needs analysis. So before you actually go out and start, you have to know why you want to do a palliative care program. You also have to know if there's an actual need in your region, your area. So what existing programs are there already in your area? There are hospital inpatient, nursing home, palliative care programs, and what healthcare services are already in place. One of the reasons that a lot of people are looking at palliative care right now is that palliative care can reduce the cost of healthcare by an estimated $103 billion over the next 2 years. That's according to the Florida Tax Watch research they did in 2019. So given the fact that it could potentially save costs in healthcare when we know healthcare costs are going up and up and up, that is one reason to do it. It's also providing the service for the patients who fall in the gap between being in acute care systems, getting treatment for whatever their disease process or illness is at the time, versus going home and having home health. But then who's overseeing some of those symptoms for patients who have terminal illness, chronic illness, such as cancer, heart disease, pulmonary disease. Also, there's new and newer payer sources. So when we get to those, we'll go through some of those sources. You also want to know who your competitors are. You want to know what partnership opportunities are. You can't do palliative care in a silo. You have to be able to connect with oncology, hospitals, nursing homes, physician practices, primary care practices, because palliative care is that connection to all of those services. So the more partners you have, the more successful you will be in your palliative care program. You also need to know how informed your community is about palliative care. When palliative care became a recognized subspecialty of care, they kept the name palliative care, and it confuses people between hospice and a separate entity of palliative care. All hospices provide palliative care services, meaning they do comfort measures. They take care of the symptoms. Not all palliative care is hospice. You do not have to have a 6-month or less diagnosis for palliative care. So there's a lot of training that has to go in when people are in the hospital. even if they're just newly diagnosed with, say, lung cancer, palliative care can come in at the same time they're starting their treatment to help with some of the side effects of the treatment, some of the adverse effects of the cancer itself. And it has shown over the years that it actually improves the outcomes of chemotherapy and radiation if they have palliative care going along with it. Problem is, you tell somebody you have cancer, let's get you on a schedule and let's pull palliative care. They hear hospice and they think they're dying. So it's a challenge to get people to understand that palliative care does not mean you're dying. Palliative care means we want to help you feel better. And how much education and marketing are you going to need to do in order to create a successful palliative care program? So you also will need to decide whether you want to register with the National Palliative Care Registry. It's a good idea. It helps you plan for the measuring and monitoring that you're going to have to do for symptom management outcomes, and all of that information that you build using the resources and tools from the registry will help you market your program as you move along. The Center for Advancement of Palliative Care also has so many tools that you can use, from actual metrics, national benchmarks. They have tools for documenting, and they have recommendations on there for every step you need to take to start a palliative care program. You also, if you're doing an outpatient or community-based palliative care, those are less prevalent than services in inpatient settings. Like hospitals, bigger hospital systems typically now have some type of palliative care program. The problem is, if they don't have a home-based program, there's no follow-up once the patient goes home. You have the services, the symptom management. They give you ideas for how to handle your side effects, any kind of symptoms you're having, but then you go home and there's no one to follow up on that palliation of your symptoms. So right now there's 136 hospitals with an acute palliative care program. Only 18% had an outpatient program. So there's opportunity. 42 hospitals offering pediatric palliative care programs. That's only 19% of those had outpatient services. So imagine having a child that needs symptom management. You want to be in a program that's going to also be there for you when you're at home. And the more there's palliative care in the home, the less frequently a patient has to go into the hospital. Less frequently there's the 911 urgent visits, emergency room visits. Inadequate medical and nursing workforce is one of the considerations when you're looking at starting a palliative care program. Are you going to be able to hire the right people to have a high quality palliative care program? It's recommended that you use palliative care specialists, board certified physicians to be your medical director, nurse practitioners who are certified in end of life care or hospice care or palliative care. Just because it is a subspecialty, there is a special passion and a special education that you need to know how to just treat symptoms versus a disease. And there aren't a whole lot of people who are board certified in hospice and palliative care. So the more we can get those people certified with the board of the medical boards, the more we be able to have palliative care options available. In a qualitative study of community-based palliative care, leader perspectives on staffing, there were major categories that emerged that influence community-based workforce. Staffing models and recruitment are influenced by the setting. Again, inner cities and just outside the suburban area, you're probably going to have more access to staffing than in rural areas. There's a lot of turnover in hospice and palliative care, which anybody who's working in hospice knows in some areas turnover is quite high. Burnout is high, especially now that we've gone through COVID and all of the special challenges that brought. Telehealth has been helping, and many palliative care programs have incorporated telehealth into their services as well. Also, communication skills. As a nurse, I was not trained how to talk to people who were dying. I was not trained how to tell a family member who didn't know that their loved one was coming on hospice that they need hospice. I learned that through my hospice training as I went into hospice. It's not bedside conversations and conversations of maybe it's time to stop the treatments and because the treatments are making you sicker. They don't teach you how to do that. That's something that you learn through doing. And some hospice and palliative care programs are better at training the conversation and others are not. So you want to make sure if you're going to have a strong palliative care program that's going to build and grow on your outcomes, communication skills are going to be a priority. You also need a business plan. You really need to sit down and think about, why do you want to do this? What is it that makes palliative care something that you really want to do for your community? You need to come up with the vision for your program. How will your program be different from others? What defines your program? There's always this talk about your elevator speech. What can you say in an elevator ride that's going to convince somebody that they should look at your palliative care program versus your competitors? You're going to need a mission statement, a description of the services you will be delivering, what services, how they'll be provided, who you're going to serve. You want to think about the diagnoses that you're going to work with. Typically recommended, you look at cancer, heart disease, pulmonary disease, or renal disease to begin with. You want to make sure that you are looking at patients who are actually going to have symptoms that need to be managed, whether it's through the treatment they're receiving or the disease itself. And all of these disease processes, you can start palliative care right from the beginning. You don't have to wait until they're ready for hospice to do palliative care. The goal of that would be to keep them out of the hospital, to keep people aware of what their options are throughout all of their care, and not just following one track until there's nothing else we can do and you need hospice and the patient is not prepared for that. So you really need to think about what you want your palliative care program to say to the people in your community. So you need to know what the needs are, which we already discussed. You need to know, do you want to be a certified palliative care program? What's involved with becoming certified? What do you need as far as staffing? You need to look at how much it's going to cost to start a program. What are your financial resources? How many patients per nurse practitioner are you going to have? You also need to know what your payer sources are. Do you want to work with Medicare Advantage plans or just straight Medicare? Do you want to be in network with third-party payers so that you get consistent reimbursement based on your coding? Medicare, Medicaid, private pay, those are all issues you need to be looking at. You also need to think, do you want to be nonprofit or for-profit? And what kind of resources open up to you in either one of those categories? Staffing for palliative care can be very similar to hospice. A full-fledged large program is going to have your physician, medical director, nurse practitioners, registered nurses, dietitians, social workers, and chaplains. Palliative care can also use alternative therapy. One of the things you need to know is that physicians, nurse practitioners, and social workers at clinical social working are the only ones that are reimbursable right now. So if you're going to have a full program, you have to figure out funding to cover those other staffing needs. Let's see, oops, went too far. Define the disciplines that you'll start with. A medical director will be a necessity. Somebody has to be overlooking the whole clinical piece. Define how you wish to utilize this. Do you want somebody who's hired? Do you want to contract with somebody? What are the differences? What are you going to get from a contracted physician who's got a full-time practice versus a physician who's going to be dedicated to you and your patients? Nurse practitioners can perform most, if not all, visits for palliative care. And you'll need office staffing for phones, scheduling visits, processing orders, mail, and if the person's going to take verbal orders, it can be a medical assistant, office assistant, or an LPN or LVN, defined by your state's scope of practice. How many patients can one provider handle on their panel? What's the census? So you're going to hire another provider. If you have a nurse practitioner going out and seeing patients, can they handle 100 patients? How often are those patients needing visits? So you kind of have to look at how many patients, how many visits, what diagnoses are going to require more visits, or what symptoms are going to require more visits. How many visits per day can somebody make? If it's just in the home program and these are patients living in different areas of your region, how much travel time is it going to take? Initial visits generally require 60 minutes to get all of the intake information, all of the past history, and then to do an assessment. Other visits could be 20 to 30 minutes depending on what's going on. So you have to kind of look at scheduling that out too. A palliative care program set up in a nursing facility would have a potential for more daily visits, but maybe fewer patients. So you have to look at that too. Can they see 6 or 8 patients in a day because it's all in one facility, or are they traveling around to 6, 7 different facilities? The hospital inpatient program, obviously, you're not going to have travel time because you're going to be based in the hospital. You're going to go from room to room. But again, how many rooms, how many referrals are you getting from the attending physicians in the hospital, and how critical are the patients at that time? Because they are in an acute care setting. There's probably the whole conversation about symptom management, where they are in their disease process, and getting them to know that if they're coming to the hospital more frequently, they're probably getting closer to the point where treatment's no longer working. Marketing and partnerships, like I discussed earlier, you need to align your program with partners. Educate your partners on the value of palliative care. We'll get into some metrics in a little bit, but you want to use those metrics and benchmarks to justify the quality of your program when you're marketing to partners. And when you're just starting and aligning yourself, you want to use the benchmarks that are already out there to show that you can either do better or at least meet those benchmarks. The good thing about getting into palliative care now is that people have been doing it for several years, so there's already so much information out there, benchmarks on pain management, shortness of breath, medications, how to start a program. There's tools, so it's a great time if you're looking at starting a palliative care program. You also want to look at residential facilities, senior community centers, and support groups like the cancer support groups, the Alzheimer's support groups, if you generally end up going into the Alzheimer's group. But support groups can be a great place to find people who are interested in getting palliative care started in your program. And sometimes you get volunteers and help and some financial support from those people. So items that you need to get started, obviously, a medical director. And you probably want somebody to be the administrator, because there are policies and procedures and formularies and quality and metrics and benchmarks and everything that you have to manage for a program like this. So you want somebody who has some knowledge on how to run a program like that. You have to enroll in your insurance companies, whether it's Medicare, Medicaid, third-party payers. You want to look at the benefit of being in network with third parties versus out of network, if your services will even be covered if you're out of network. You want to establish your rates. Typically, these are based on Medicare rates, so there's coding and you have to set up the rates. And then the super bill or fee ticket, or you see them when you go to the doctors. Before EMR systems, it was a piece of paper and they used to circle the codes that they were going to bill, but they also had charges to them, and that's how they did the billing. Now with EMR systems, it's usually done through the documentation, but you still need to know what you're going to charge for specific codes. You need to decide if you're going to be electronic or paper documentation. I would hope everybody that could possibly have electronic medical records does, because it is so much easier to make sure that you are staying compliant, that you're billing, your scheduling, and your documentation is done. But if you do decide to do paper, there are tools out there that you can use to help start up a program. What procedures are you going to have your nurse practitioners doing? Do you need office space? Are you going to do virtual office space? You're going to need a phone number, a fax number, website, and an email, and standard supply kits for providers. Screening assessment tools. You want the screening for appropriateness for palliative care. You want to make sure that the patients really have a life-limiting illness, not necessarily at the terminal stage, but they have an illness that is being treated that is either going to have symptoms for the illness or symptoms from the treatment that you can manage. Symptoms like pain, respiratory, and other symptoms that you might need to be looking at. You want screening and assessment tools for those to make sure you're hitting all of your bases. It's recommended a palliative performance scale to use to show decline in a patient. Gives you an idea of when a patient should be referred to a hospice program. There's also an ECOG performance scale. The Eastern Cooperative Oncology Group has come up with an ECOG. Many times you can use that scale also to determine when treatments are no longer beneficial for a patient. There hits a point where that's when you start to have there are other option conversation. Advanced directives available for patients or families to use if they don't have access to the state website. And then you, of course, are going to have patient education tools, so you can teach them things that are maybe non-medicine related that they can do, like having a fan to help with shortness of breath, or relaxing, or meditation. So you can have all kinds of tools, even for family members if they need to learn how to transfer a patient who's bedbound, or whatever the case may be when they're in the middle of their treatments. Reimbursement opportunities. So Medicare and Medicaid do cover some treatments and medications for palliative care. They include visits from doctors, nurse practitioners, and social workers. Social workers have to have, at this point, the last time I checked, they still have to have a mental illness diagnosis code that they're working for. So if they're just helping them fill out Medicaid paperwork, those visits are not billable. But if there's a clinical reason for them to be in there for social services, then they can bill those visits. Palliative care is covered under Part B benefits, which is very different for anybody who's been doing hospice in Part A all these years. Part B is not a per diem. It is paid by the what they call a procedure code, a CPT code, and it's the patients could also have copays that you'll need to have some system in place to collect those copays. Private insurance, many of the third-party payers are providing some coverage. In fact, there was recently 27 states now have laws designed to provide palliative care. So it's actually increasing people's ability to get payment and reimbursement for palliative care services. That was 27 states in 2018. So hopefully that's getting higher and higher. I think the more government sees that palliative care helps reduce the costs, then the more that insurance companies are going to start paying for it. Long-term care policies, there are some long-term care policies that do cover palliative care.
Maureen, I think we might have had a little glitch. I think she's actually trying to call back in. Here we are.
No, if you can't see
There we
me.
go. You're back.
Okay. Sorry.
No worries. Technology.
Yes. So the nonprofit versus for-profit. A for-profit can raise money from private investors for money to use, but they have to have equity or dividends to shareholders, and a return on investment is expected. In the nonprofit world, you can seek donations and grants from individuals, foundations. They're generally, it is a social return versus a financial return on those. What I've seen in the last probably 10 years is even if the hospice program doing palliative is for profit, their palliative care program has been not for profit, because when they started, there were fewer reimbursement resources. And now that that's improving, you really have to kind of weigh the costs and risks and benefits of either one. Coding for palliative care, again, it's Part B. You have to use evaluation and management codes using the CPT codes that correlate with those services and the complexity of care. Visits, again, nurse practitioners, doctors. There are some that are starting to pay for physician assistant visits. Not all of the payers are paying for physician assistants yet. And then clinical social workers. The codes are based on the patient type. Are they a new patient to your program, or have they already been established? Where are you providing the service? What services? The medical necessity and the appropriateness for those services, and the level of service. And there's 4 levels for billing Part B. Problem focus, expanded problem focus, detailed, and comprehensive. So the more diagnosis as a patient is dealing with and comorbidities, and the more symptoms they're having, the more complex the visits generally are, and that raises your coding level and then raises your reimbursement rate. But you have to make sure that your documentation matches what you coded your visit for. Okay, marketing for growth. Goals for marketing should be to build awareness about your program, correcting misperceptions and myths about palliative care. You want to remind providers why palliative care is necessary and why it's so important that they support a palliative care program. Focus on what differentiates you. Even in hospice and home health, people will go through, well, we provide this, 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 and this. And the answer back is, yeah, so does everybody. What makes you different? What makes you special? You know, is it the people you've hired? Is it the services you're providing? Is it that you're the only one in the community who can do these things? Is it that everybody else in your region is in the hospital acute and you're going to do post-acute, whether they're in a facility or at home? What makes you different? Always in marketing, under promise so you can over deliver. You want to make people think that you've given them more than they could have ever expected. So you don't want to go in and promise the world and then you can only give them the town. You want to be able to promise them the town and then give them the world, and that is what helps your programs grow. Reflect on the values of your program. Use social media to market education, share events and stories, publish a blog, get people talking about symptom management and end of life care, and have these conversations with people before they need them, so that when they do need them, it's already in their head somewhere. They can get that information from their brain and say, hey, this isn't as scary as I thought it would be. There's people out here who can help me. Build a really comprehensive website for your palliative care program that includes caregiver tips. Put a whole section for caregivers, where they can get support in their neighborhood, where there's support groups that they can join up, how to get a patient from, they've just come home from chemotherapy and they can barely get out of bed. How do you help them get out of bed without causing more injury? Host bingo games at community centers, join your chamber of commerce. Lunch and learns for providers. If you have a medical director who will go out and talk to other doctors and provide them lunch while your doctor is training them and teaching them on palliative care, that tends to be more successful, because doctors like to listen to other doctors. Even as a nurse, when I'd go to talk to doctors, they'd be looking for my medical director. So I could have talked to nurse practitioners, and I could talk to the nurses, and I could talk to the front office, but the doctors really wanted to talk to the other doctors to say, what are you going to do for my patient? Right. So educational services for senior citizens groups and support groups and radio and TV and talk shows. And don't forget, the schools all have PTA, PTO, PTSO, depending on how they define themselves, groups. Go in and talk to these people. The parents of these high school and elementary kids are probably taking care of their parents at some point. To have the information available before their parents need it will help them make decisions with their parents when they do need it. You want to make sure that you're always continuing your partnerships. You want to go back and talk to your partners. You want to make sure you have a strong alliance so that nobody else can come in and undermine that alliance. Don't just partner with somebody and then never talk to them again. Give them feedback. Get them to help you make decisions on how to do different things in the future. Help them feel like they're part of your program, even if they're not. The more they feel like they are helping their patients by helping you, the more successful your program will be. Make sure you're utilizing any surveys and metrics and person-to-person meetings. Be responsive to any concerns or issues. Don't just let them roll off your shoulder and say, oh, they just complain a lot, or they're never happy. Or actually look into the complaints and concerns and make necessary changes, and do it quickly. And then go back to the person who complained and provide them the feedback of what you did to make the changes, and ask them for time to prove that you heard them and you've made those changes. And then there's always a quality component, which everybody hates, and we have to do it no matter what we're doing. So there are metrics out there for palliative care. You want to be able to identify your strengths and weaknesses so you can make improvements. There are quality improvement metrics for palliative care on measuring outcomes, patient satisfaction surveys. You need to be able to show value to your stakeholders, whether they are your grants and foundations who are supporting you, or your private equity companies who are supporting you. You have to be able to show value of your program. You're always going to compare yourself to national benchmarks, and you want to make sure your operating costs are within reason. You don't want to be throwing a ton of money out and not being able to get enough money to not even necessarily to have a profit margin, which we all want, but just to make ends meet. You want to make sure that you're keeping a close eye on your operating costs. So some metric examples, workload calculations for your providers. How many visits are they making? How many complex visits versus just routine visits? Are your doctors or your nurse practitioners seeing these patients? If your nurse practitioners, are they billing with something called incident 2, which is only 85% of what a doctor would get reimbursed? You need to know where your calculations are for workloads. You want to know how many consults, initial consults versus continuing consults. You don't want somebody to just have an initial consult and then there's no follow-up for those patients, because that's going to impact your reputation. If you just do one visit and then you disappear, you're not going to be able to build your palliative care program. And you want to make sure that your providers are actually working for your company. So, if you've got somebody out there who's doing 2 visits a day and somebody else who's doing 8 visits a day, and they're both being paid full time, you've got a discrepancy you have to fix. Percentage of hospital deaths. So patients who are receiving a palliative care consult when they're admitted and then die in the hospital. So this would be a hospital-focused palliative care program. How many of them died? How many of them had palliative care earlier in their disease process? How many patients died within 30 days of being discharged? Hospitals have metrics they have to manage, and you want your palliative care program to come in and be able to prevent some of these readmissions that they get. Sample outcomes, clinical patient reported, the pain score reported at initial encounter versus what their pain score was 30 days later. Family satisfaction of care, costs and utilization. So, cost of care in the final 6 months of life for patients seen by palliative care. Again, if you tend to see people who had palliative care prior to hospice, don't have as much need for pain management until the very end because they've already been palliated. They already understand what the next step is. They already understand the process. So you're not seeing the repeated visits to explain what the disease process is. You're not spending money on continually having to send a social worker out for your hospice program because the family didn't know the patient was dying or the patient didn't know they were that close. So palliative care tends to help offset the end of life costs that come in. And you also see fewer 911 calls when the patients are in hospice if they've had palliative care prior to hospice. National Coalition for Hospice and Palliative Care, an organization that advocates for healthcare policies. Their goal is for patients, families, and caregivers to have access to quality hospice and palliative care, regardless of their diagnosis, prognosis, or age and setting. So they've come up with 8 domains of care that they consider the foundation for gold standard care. The first, the 8 of them are listed here, and then we'll just kind of quickly go through each of the 8. Structure and process. You want to make sure there are principles and practices that can be integrated into any healthcare setting. So what you do with palliative care, you want to make sure that if you start palliative care in the hospital and they go home, that there's going to be some continuity of care between the different services, between the different locations. Interdisciplinary teams, you want to make sure that everybody is working together to build a comprehensive care plan for these patients, even before hospice. So palliative care has to have IDT meetings just like hospice does. You have to have everybody involved in the care weighing in on what they're doing so that one person's not saying and doing one thing and somebody else is doing something that's counterintuitive to it. Physical aspects of care, care of seriously ill patients. You have to have an understanding of the patient's goals. This is something that isn't new to hospice. We're supposed to always have patient goals in mind. It's supposed to be their goals, not our goals. If a patient has pain and they're rating it a 9 or a 10 and they say they're happy with it's a 6, we should be happy with a 6 and not push them to say it should be 0, because maybe they don't want to be that medicated. Maybe they're okay with a 5 or a 6 so they can still communicate. We have to learn to understand what the person's own goal is for physical, functional, emotional, and spiritual well-being. So you can see there's a tie-in for palliative care to hospice. They kind of took the best of acute care and the best of hospice and tried to roll it into this coverage of care that provides a continuity in transition from one setting to another. Psychological and psychiatric aspects of care. You want to be well-rounded and understanding, again, culturally sensitive mental status issues. You need to be able to screen for any kind of psychological or psychiatric issues that may impact your treatment. They may be on medications for a psychiatric issue that will be more impacted by, say, pain management. So you have to know what those are, and you have to establish that rapport with the patient so that they're honest with you and tell you what their issues are and what they're being treated for, maybe in a different setting. And sometimes you have to refer those patients out to psychiatric care because they haven't had psychiatric care. And typically palliative care and hospice are not trained in psychiatric health. Social aspects, again, what social factors are impacting a patient's ability to get health care, to have quality of life? Do they have a support system? Do they have family? Do they have private hire caregivers? Do they have a home? Are they homeless? You have to know what is going to interact with your ability to provide care. And hospice has always said home is wherever the patients live. The same is true with palliative care. And some homeless people do have health insurance. They might have Medicaid. They just don't have a home. You just have to be able to adapt your program to work within the confines of whatever your patient and their family or caregivers are living with. Spiritual, religious, and existential aspects of care impact even palliative care, even if it's a year or two before hospice comes in, because there are some religions who don't believe in blood transfusions. There are some religions that feel that they are, or their culture, their spiritual aspect is that pain is a punishment for the way they live their life and they have to suffer through it. You have to be able to understand that so that you don't get into a fight or an argument with the patient on how to provide care. You want to make sure you understand where that patient is, not where you are. So your beliefs might be different than theirs. You have to be able to accept that and move forward with their care. Cultural aspects, same kind of cultural sensitivity. Again, pain is probably the easiest one on cultural sexual orientation. Again, if in their culture they are taught that if you're in pain, you're stoic, you don't show signs of pain, you're going to have to know what their signs of pain are, because they're never going to tell you. You don't want to come in prejudging patients. So if you have biases against people who are refugees or from a different country or identify differently, there's going to be a roadblock, a barrier to care. You have to be able to let your prejudgments of people or cultures go away so that you can open the conversation. If you can't do that, or you have a staff member who can't do that, you have to replace that staff member for that patient. You don't want your people to be the barrier to care. Care of the patient nearing the end of life. Again, this is where hospice and palliative care kind of intermix with each other. There comes a point where palliative care is got to be the person or the service that explains treatments aren't working anymore if they're in a palliative care program. The majority of doctors who are not palliative care or hospice are going to leave this conversation to the palliative care team. And you have to be ready for it. And so again, you have to know the whole person. So it's hard in a hospital inpatient palliative care where somebody comes in, the first time you're seeing them, they're already hospice appropriate. And they're in significant pain or shortness of breath. They're in a crisis. You're managing them, but then what? You don't even know this patient because there's no established care, which is why it's so critical for palliative care to be involved at the beginning of a diagnosis and not at the end of the disease process. So that's where your alliances and your partnerships will help you get in sooner. Again, the interdisciplinary model is also recognized in palliative care. And you want to make sure that there's early access to hospice support. So there are some programs, and with Medicare and Medicaid for pediatrics, children can have curative treatments alongside hospice. So they can actually get both curative treatment and hospice until the curative treatment is no longer effective. They did that for several reasons. It was part of the Affordable Care Act, and it has helped patients, families, to get the support they need from a hospice program while their children are still being treated for the disease. And just using that model alone can show you how beneficial palliative care can be for adults if you get it sooner. And then they end up coming into hospice sooner because they understand and they've already been talking about it. Ethical and legal aspects, that's always going to be in there for any kind of healthcare. You want to make sure that what you're doing is ethical, and you want to make sure what you're doing is legal. You want to make sure that the best interest of the patient is always the focus for any decisions. And there are issues coming up. There are several states now that have legally accelerated death options, or better known as physician-assisted suicide. There's medical marijuana now, where there are states that allow it and states that don't. These are all issues that you have to be able to address and know what your state laws are and what the federal laws are and which ones have priority. Also, care of people who are developmentally disabled or have psychiatric illness. Who's speaking for them? Can they speak for themselves? Are you talking to the right person to make decisions? There are, even in hospice, there are times when families will say, well, I don't want them to know they're on hospice, so I'll sign them. And you find out the patient has full capacity. They have to be able to sign their own consents, and it's informed consent. So they have to know they're coming on hospice. Same thing in the palliative world. You can't just start providing services without consent. So make sure when you get ready to start your programs that you have the legal backup and know what your legal rights are and what the patient's legal rights are. And then there's a slide that has some references and resources if you want more information. The Centers for Advancement of Palliative Care, the Shiley Institute for Palliative Care, American Academy of Hospice and Palliative Medicine, and the National Palliative Care Registry are all good resources for palliative care, tools, education, continuing ed courses for your staff, resources, training. I can't tell you how much over the last 17 years I've used these 4 resources for help in doing things. And then we're to the questions.
Awesome. Well, I really appreciate that, Maureen. It was very, very good information. And yes, we actually do have quite a few questions here. I guess the first one we'll start out with: have you found that standalone palliative care programs can generate enough reimbursement without fundraising and other community support? Or are there programs you're discussing part of a home health or hospice agency? And that was posted by Margaret Hadley.
So it's getting better now to have reimbursement. But again, because you only can be reimbursed for doctors, nurse practitioners, and social workers, your support staff, there's no financial support for. So at this point, it's still better to try and find some kind of financial support through loans or grants or scholarships, or if you're nonprofit, through raising money, donations. There are a few standalone palliative care programs that are out there that are working. They appear to be successful, but the reimbursements is really coming along now. So it probably need a few more years to see whether a standalone could actually survive on reimbursements alone.
Awesome. Thank you. We've got another one here. It's kind of a two-part. Is the preferred physician bill Part B or hospice? If the hospice bill is Part B, from a legal standpoint related to corporate practice laws, does this influence if the doctor bills Part B with his or her practitioners or the agency?
So if you're doing palliative care, you would set up an NPI number for your palliative care, and you would only bill Part B. So your palliative care program would bill for your doctors and your nurse practitioners seeing the patients. So separate from hospice, which is one of the reasons you want to make sure that it's really separate from your hospice program. I know a lot of people have hospice and palliative care in their name, but your palliative care program should be a separate entity and keep things separate. So if you're going to utilize hospice staff in your palliative care program, you want to set up a contract or an agreement with your hospice for those hours that you're actually using that staff. So like, say your hospice has a full-time nurse practitioner, but your hospice isn't big enough for that person to do full-time work, you could contract that nurse practitioner to the palliative care program to pick up maybe 20 hours and do visits for palliative care. That would be billed separately under Part B with the palliative care provider number.
Okay.
Hope that helped.
Thank you. Yeah. And here we have one on social workers. Does the social worker need to be a licensed clinical social worker to be paid for the visit?
Yes.
Very straightforward. We've got a couple others where we basically had some questions asking for some resources, and we'll provide those afterwards. We can reach out directly. But we did see one. Let's see, can this be done out of a home health rather than a hospice, and other considerations in some states? So certificate of need considerations in some states.
Right. So, I mean, your home health program can have a palliative care program. Again, always recommended to make them two completely different entities with two completely different NPI numbers, because even in home health, you're not billing Part B, you're billing Part A. So you want to make sure that your palliative care is billed to the right resources. And for Part B, you have to have, it's a separate 855A form. It's a separate billing NPI number. So you just want to have a clean line between your two programs.
Perfect. Awesome. And last question here that I'm seeing is there a section of the CMS manual that covers palliative care specifically, to your knowledge?
No. So typically what you're looking at for rules and regulations for palliative care is more of a physician's office. So the billing, the CPT codes are very similar. The evaluation and management codes, it all follows physician billing. And even in the home, it's just you're changing the setting, the location of where the care is provided, but it's set up very similar to a private practice medical office. So you're scheduling visits. You don't have to be available 24 hours. You can, but you don't have to be. You could set it up like a house calls program where all your patients are meeting Medicare requirements for homebound status and doing house calls visits for it. But not everybody's going to be on Medicare. So, you can do home visits depending on what's going on with the patient. So In the grand scheme of things, palliative care as a separate service is relatively a baby. And, the insurance companies and Medicare Advantage and third-party payers and Medicare, Medicaid, they're all trying to figure out how to make it work and not cost an exorbitant amount of money. So there's always going to be changes to the way things are done. But like I said, those 4 resources we did provide have great information on what you need as far as documentation and legalities and everything to get started, the paperwork that you need for different insurance companies. I did see one flash by about EMR for palliative care. Mm-hmm. Again, if you find an EMR system that works for physician offices, it will typically work well for palliative care. There aren't too many that are specifically, in fact, I can't think of one that's specifically set up for palliative care. I'm sure they're trying. I know that there are a couple of hospice EMR systems that are trying to build out for palliative care. MUMS was one. I think Home Care Home Base has been talking about it if they haven't started it yet. There are programs like Cario, it's K-A-R-I-O, that can be used. It's a good scheduling and orders tracking and message. But if you look at your own doctor's practice and find out what EMR system they're using, things like Athena or EMDs, so there's thousands of them out there pretty much. It really, when you're starting your palliative care program, you want a basic program that's going to let you do scheduling, orders management, and some kind of messaging between your staff and providers and between the patients and the providers. So go basic at first, go slow, go small, and grow your program through the quality of your program, and make sure that you're billing appropriately so you don't get in trouble.
Right. And I did have one really quickly when we were touching on the certificate of need considerations in some states. Could you maybe go through that answer just one more time? Could that be done out of home health rather than hospice? Could you maybe just repeat that? I think we had somebody that just wanted to retouch on that.
So the home health rather than hospice. So I'm not exactly sure what is meant by can it be done out of a home health. So home health can create a palliative care program, okay, but it won't fall under home health billing and reimbursement. Those visits for symptom management for a palliative care program, those are specific to comfort care and symptom management of a disease or treatments. Home health is usually in there for a specific reason, whether it's orthopedic or wound care, or they have to have a specific cause for home health to be involved, and there are specific criteria that have to be met. Palliative care is a little bit more open-ended. So again, a home health agency can start a palliative care program, but they should separate it out just like a hospice should separate it out.
Sure. And I know we're getting close here to the top of the hour, and there was one more question that came in. So is there reimbursement for telehealth under palliative care, to your knowledge?
So there is reimbursement for some visits depending on the reason for the visits, and I don't have the specifics, but I could certainly look those up and put those out to the people who are attending.
Perfect.
And then I saw the certificate of need part. Again, I'm not an expert on certificate of need states, and I know that they can be a challenge, but from what I know, there's at least 2 states that require you to go through certificate of need for palliative care, depending on how you start it up. So if you are already licensed for hospice and palliative care under your certificate of need, and I want to say that's Florida, But if you are licensed for hospice and palliative care already, then it kind of attaches, you just create the separate entity for your palliative care so you can bill Part B. Again, I would want to know what state, and I could look up information and provide that information. BlackTree would be more than willing to help with any of this, with the forms, any of the tools you need, any help you need in setting up, doing a needs analysis. We have experts in all those billing, financial, all those areas that we can help anybody who's thinking about starting up a palliative care program.
Yeah. With that, definitely don't hesitate to reach out. That's one of the reasons that we're here. So we also hope that the information today that was shared was beneficial to everyone. We will be following up again with a link that'll have a replay of this webinar, along with probably some key takeaways just from this event. So be on the lookout for that. And I know a lot of times too that, when you get asked that infamous question, are there any questions? Sometimes when you're put on the spot, they don't really come to mind. So if anything pops up between now and this afternoon, don't hesitate to reach out to us directly. You see Maureen's information here, and I'm sure you'll be receiving emails from us again here shortly. But thank you all for hopping on today, and we look forward to having you on more of these webinars in the future. So again, I'm Alex Freeman, Director of Business Development here at BlackTree, and hope you enjoy your afternoon. Thank you.
Thank you.
Thanks, Maureen.